I'm just going to try to take you into the world of labs. You're going to be looking at these, hopefully after this class, with a little bit of a different perspective. I'm going to try to keep it to things that you really need to be worried about if you're going to be transporting somebody. You know, always patients are going to have some tests done before they're transported somewhere else. Many of those you're not going to care about. There's going to be some that you're going to want to know about because they're going to affect what's going to happen, potentially going to happen while you're transporting that patient. So just to start off, you've got the lab tests, the blood work, the serology. We'll talk about some of those things in details. Imaging studies, things like chest x-rays, films of lower extremities, CAT scans, MRI. Those are all the imaging techniques that are dealt with. Physiologic tests deals with things like 12-lead EKG is an example of a physiologic test, or a stress test, something that looks at how the body responds. Some of these results are immediately available for you. You know, CAT scan, now you can pretty much do that in a head CT in under 10 minutes and put it on a CD, or even now send it through Epic to get it to the other facility. So that stuff is available for you to take oftentimes. Body fluids that we look at, pick a body fluid. It can be looked at. Tests can be run on it. Some of it's important for you, some of it's not. Somebody has C. diff in their stool. You want to know about that because that's something that is not so likely to affect you, but more likely to affect another patient that is being transported in the ambulance after that patient if you don't go through proper decontamination of your equipment. So that sort of stuff is important to look at. All lab values, all lab tests have an abnormal value, all right? Something that's outside of the range. More importantly, also in hospitals in particular, there are critical values assigned to these tests that we're talking about. The abnormal ranges, I might have a low potassium, but I don't necessarily care because it's not that low. But I might have a critical low potassium level that I need to do something about right away. So those critical values are things that in a hospital setting, usually the lab calls and says, hey, I have a critical ABG result, or I have a critical potassium level. There's no time for someone to go even look in the computer and stumble upon the abnormal value. It's so abnormal that minutes count, that an intervention is required. So that's what we mean, or I mean, when I refer to a critical value. The categories of these tests: hematology looks at what is part of the blood cells, the serum of the blood, the white cells, the red blood cells, all the platelets, the clotting factors. Chemistry, we're going to be talking about looking at electrolytes primarily. Potassium, phosphorus, calcium are the big ones that we'll worry about. Microbiology is looking at things that are growing in a specimen, a blood specimen, a urine specimen. Microbiology refers to the cells that are to be present there and not normally present there, like if somebody has an infection. Serology tests are done. I can't think of a serology test off the top of my head. I was trying to think of one this morning that would be important for a paramedic to know. You know about serology testing because when you got your hepatitis B vaccines, you were tested to make sure that you converted and had an antibody. So that's what serology tests are looking at. They're looking at the presence of antibodies. Either you had an active infection or you were immunized against something, and we hope that you have an antibody for it now. Pathology is looking at a myriad of things. Most commonly, pathology refers to specimens, tissue specimens, specimens from the lung, where they actually look at what the cell makeup of is. Is it a cancer? Is it an infection? That's what pathology results are looking. Pathology results tend to be, out of all the things listed here, along with serology and most microbiology, things that I'm not going to be able to draw that lab and turn around and even in an hour get the results back on it. Some of the pathology tests, they'll do a quick slide read and get a preliminary result back on it. But those three things are not things that you're going to see an immediate turnaround. The hematology, the chemistry, that's going to be things that usually within an hour, we're getting all of those results back with some exceptions. If you're working with a portable device that can give you that test result, that can happen in a matter of minutes, right? You drop of blood on the machine and it gives you the results. As far as these lab values go, there's a couple of ways that they're looked at. Labs that are evaluated quantitatively are things that we apply a numerical value to, all right? How much of something is in the blood. Qualitative testing is just a simple yes or no answer. So I take a urine dipstick and I dip it in a urine sample and it's positive yes for protein. That's a qualitative test. The reference values that are applied to all of these levels in the body are fairly standardized across the country, even across the world. The units that are used are understood around the world. They're based on a bell-shaped curve, so what most of the people's potassium level is has become what is the normal level for potassium based on literally millions of samples over the course of years. That's how that stuff is determined. Understand as well, as I'm sure you do, there are some age and gender-related differences in lab values. Pregnant women have a higher red blood cell count late in their pregnancy. That would be normal for them. Young children have different blood cell counts than an adult does. So just be aware of those things, that there are some things that you need to be paying attention to. Specificity is really talking about how well a specific test detects a disease. And understand that there is no single test out there for anything that is 100% accurate. There is always this question of reliability for any of the aforementioned pathology testing, serology testing, chemistry testing. There's always potential for there to be erroneous values, all right, and makes them not reliable. That's why if you work with an iStat, one of the big pieces of it is the daily QA that you have to do on it. You're just making sure that it is going to maintain its accuracy over time, all right? And the lab at the hospitals does the same thing with their devices. They're more sophisticated devices, but multiple times a day they're constantly recalibrating those devices to guarantee, at best, the accuracy of the most accurate results that we get back. Like I can give you an example of IV pumps, for example. There's an allowed 10% variability. So if it says it's 100 cc's an hour, it could be 10% above that or 10% below that and still be, the FDA says, hey, that's cool. And I'm sure it's not that different. A 10% variability is usually, but I can't speak to the bazillions of lab tests that are out there. But of course, there's going to be some allowable range of accuracy, what a lab will tolerate before they recalibrate the machine. All right? They're not going to call back a critical value of something if they don't know that the machine hasn't been calibrated properly, right? The units of measurement, fairly standard, but are using the metric system, especially when we talk about chemistry values. We're going to be talking about the metric system. The other system of unit measurement that we use is this SI units. It stands for International System of Units, French. This is also a very common way that lab results are reported: millimoles per liter, milligrams per deciliter. Generally, what you'll learn are the normal values in the environment that you work, and you're going to forget even these units of measurement. Where it can mess you up is that, in fact, one hospital may use milligrams per liter, and another hospital may use millimoles per liter for the same test. The normal values for either of those is very different. So you almost have to remember what unit of measurement is being used. I'm very comfortable with the lab results that I see every day where I work because it's been the same. If I open up a journal article and look, and they'll talk about a potassium level being normal of 1.2. I'm making this up right now. But they're using a different unit of measurement. So you always have to know what unit of measurement is being used when you look at these values. You'll learn very quickly in your environment what the normals are with the standardized units of measurement that you'll use. And in southeastern Wisconsin, it's pretty standardized. We're only probably using a couple of labs in the whole in the whole state, right? Blood is collected typically in these vacuum tubes, and they all are different. They're color-coded because of what is contained inside of them. Some of them have blood thinners in them so that the blood doesn't clot. You know, it's going to be kind of hard to get a specimen of how many red blood cells there are if they're all clumped together inside of the side of the tube. On the other hand, or similarly, if I'm trying to measure someone's clotting status, I don't want any anticoagulant in that tube because it's going to interfere with the measurement of the blood's ability to clot if I have an anticoagulant in the tube. So each one of those tubes has something in it. Very typically, again, there's different manufacturer guidelines, but from what I've seen in 28 years of doing this, a red top tube very oftentimes, and you can look right on the label, it'll tell you if it has something in it, very often has nothing in it. So if you're just trying to get a blood sample and you're not knowing what you're going to do with that sample yet, it very typically goes in a red top tube because there's no preservative in it at all. Hematology is the study of blood and its elements, as I said, and predominantly today it's done automatically. They put the blood in a machine and it spits out the entire CBC, blood count, and differential. All right. Years ago, it was done under a microscope, and not too many years ago, where people were still looking at slides under a microscope to evaluate this. So let's kind of dive into this a little bit. So CBC stands for a complete blood count, and it's looking at basically all of the pieces of what make up blood, with the exception of the clear liquid serum part of the blood. Not really clear, but you get my drift. The hemoglobin level is the amount of hemoglobin in the blood. What is important about hemoglobin? Why do I need to know what someone's hemoglobin level is? It carries oxygen. I don't have enough hemoglobin on my red blood cells, I'm not going to be able to transport oxygen, right? That's how oxygen gets around the body where it needs to be. It's attached to these hemoglobin molecules. So if you don't have enough, you're not going to attach the correct amount of oxygen that your body would need. Normal values, and right away we see here where we get into this gender difference of what is normal. Men, the hemoglobin value 13 to 18 grams per deciliter. Women, 12 to 16. That would be even different when a woman is in later part of her pregnancy. It's a little bit higher than that. High hemoglobin levels oftentimes are seen in smoking patients. They compensate to try to carry more oxygen around. So if their bone marrow is working correctly, their kidneys are working correctly, they're able to increase the level of hemoglobin that is present in the body. Low values very commonly seen in chronic anemias. Also acute blood loss. You will see a drop in the patient's hemoglobin level. But when I measure their hemoglobin level, if they're jaundiced, it's not what would be present in their blood. If they're jaundiced, likely is that they're going to have elevated levels of bilirubin in their body, which is the breakdown of red blood cells. Red blood cells, when they break down, give off bilirubin, break down into bilirubin. That's what makes people jaundiced. So when you see someone that's jaundiced, they oftentimes have an excess breakdown of hemoglobin, or an inappropriate removal, like in the case of liver failure, which is most often where we think of people being jaundiced. Their liver cannot properly excrete the breakdown of hemoglobin molecules. It accumulates and it shows up, in orange skin and orange sclera, among other things. The other thing that can alter hemoglobin levels, we talked about blood loss, but if I overhydrate somebody, so if I take somebody, put an IV in them, and give them 2 liters of normal saline, I dilute their hemoglobin levels. So it's not that it's actually gone, I've just diluted it. All right? So those are things to think about as well. Hematocrit is the percentage of red blood cells. So when we talked about hemoglobin, we were measuring what was on the surface of the hemoglobin, on Red blood cell, when we talk about hematocrit, we're talking about the percentage of red blood cells. Normal is 37 to 49% in men, 36 to 46% in women. High values are oftentimes seen in dehydration. So if a patient comes in with a 2-week history of vomiting and diarrhea, maybe they're an oncology patient, they're visibly dehydrated, I measure their hematocrit, and I'm going to find that they have a very elevated hematocrit. It's the opposite of what happened when I gave that patient 2 liters of fluid, right? Now they're dehydrated, so there's just, when I draw a 10 milliliter sample of blood, there's more, in that sample, the percentage is higher of red blood cells, all right? Likewise, with low values, we see that in anemia and blood loss. That's an interesting thing about trauma resuscitation. When somebody's actively bleeding, I can measure their hematocrit, and it usually stays the same in the early part of bleeding. I don't see, because the percentage of red blood cells in that given volume is the same. They're losing red blood cells and the volume of the blood together, so the percentage remains the same, right? It isn't oftentimes in the trauma room until we give them a liter or 2 of fluid and then recheck their hematocrit where we see that there's a big drop, because now I've diluted out the total percentage of red blood cells in the bloodstream, and it sort of both artificially elevates what I see, or exaggerates what I see, plus they actually have lost some of their red blood cells because they're bleeding, right? White blood cells, this is where it gets a little bit more tricky. If I measure someone's white blood cell count, I'm actually measuring the total number of white blood cells that they have in their body. Pretty nonspecific. Normal white blood cell count is anywhere between 4,000 and 1,100. Again, every hospital has their sort of normal values. You get to know what I'm using these because this is what your textbook has. In my head, I have a little different understanding of this, but not by much. When someone's white blood cell count is elevated, you can generally make an assumption that there is some sort of active infection going on. That's predominantly what we would expect to see with an infection. Also realize that patients who have blood cancers, specifically leukemias, oftentimes have an extremely elevated white blood cell count, which is a manifestation of their cancer. It doesn't really mean that they have an infection. These are exceptionally high, what I wouldn't even expect to see with an active infection. Really quite out of the range. Also, steroids can cause a little bit of an elevation in your white blood cell count. So if someone has gotten steroids, maybe they're on steroids for their asthma, maybe they've gotten bolus with steroids because someone thought they needed it, because they had a very active infection, that can also cause your white blood cell count to go up a little bit. Low white blood cell counts are often seen in viral infections and when there is a patient that is not immunocompetent, so they have an immunodeficiency. Their body can't produce white blood cells. So chemotherapy patients, oftentimes when you see them, they will have a very low white blood cell count. When they're actively being treated with chemotherapy, most, if not all of the chemotherapies, I shouldn't say that, many chemotherapies will, by virtue of what they do, lower your white blood cell count. It can get so low in those patients that they actually are susceptible to infections, right, or at risk for infections. We can measure the number of red blood cells per cubic millimeter, and that if we do an RBC count, a little bit different than a hematocrit, a little bit different than a hemoglobin. High values of red blood cells are known as polycythemia. So you will see patients who live in Denver have a higher red blood cell count than people who live here at our elevation. Their body produces more red blood cells to oxygenate them better because they live at a higher altitude, so the percentage of oxygen in the atmosphere is less. They need the ability to carry more oxygen, so the body recognizes that. That's what acclimation to climb the Himalayas is all about, right? It's going there, acclimating yourself to the environment so that your red blood cell count goes up, one of the things, so that you're capable of still oxygenating well at high altitudes when there's very little oxygen. That's what acclimation is all about. Low values of red blood cells, very similar to white blood cells when somebody has cancer, or any circumstance in which they have bone marrow suppression. All right? Your bone marrow is where most of these products originate from, that we're going to be talking about in the next couple of minutes. So if your bone marrow is not working well to generate these things, you're going to see a low count in almost all of these. So this is the thing that always, wakes people up in the middle of the night when they're trying to memorize this, and I don't expect you to memorize it. But when I do a CBC, it's giving me basically 3 measurements: white blood cell count, red blood cell count, hemoglobin level. The rest of the information that we get from this comes from adding a differential. So you'll see that the patient has a CBC with differential. Now it's really specifically looking at all the different cells that are present in the bloodstream, not just saying, oh, their white blood cell count is high. Well, what of their white blood cells? There are many different kinds of white blood cells. Which types are elevated, and what does that mean? All blood cells start from within your bone marrow from this particular cell called a hemocytoblast. What this diagram is showing you is how that cell, another name for this cell oftentimes, you can see, comes with the next layer down, is stem cells. So stem cells originate, we think of stem cells being the original cell. In fact, it's the hemocytoblast that is the original cell. First differentiates into stem cells, and stem cells, as we know from just watching TV, are those things that can differentiate into all kinds of different things, right? That's the whole, why people want to mess with stem cells, because I can make them become anything that I want them to be if I tweak them a little bit. What we get down here at the bottom, though, is the final differential, what these cells end up being when they're fully mature. That's what the differential is looking at. Varying degrees of maturity. All right. Erythrocytes are the red blood cells. Platelets is a part of the CBC, the platelet count. These across the bottom here, basophils, eosinophils, neutrophils, monocytes, and lymphocytes are the final developed different types of white blood cells. So if I measure someone's WBC count, I'm counting all of these without knowing specifically how many of each. If I do a differential, now I'm saying, okay, well, how many of those white blood cells are each and every one of these things? And that becomes very useful, because depending on what's wrong with the patient, i.e., do they have a bacterial infection or do they have a viral infection, there are going to be more of one or other type of white blood cell, differentiated white blood cell. These are also called, some labs call them SEGs, and it gets confusing because one hospital calls it this thing and one textbook calls it another. SEGs just means it's referring to, if you look on the inside of each of these cells, is their neutrophil, and they're segmented. I can see that there's 2 little globules kind of stuck together by a skinny part. That's a segmented nuclei. That's where the term SEGs comes from. It's the same, it's referring to the same thing as if I would just say the differential. You could say how many SEGs does the patient have, all right? And you'll hear that. It just depends on where you went to school and what textbook you used. So bands are some of the more immature white blood cells. Normally, you don't have a lot of immature white blood cells circulating around in your body. All right, they quickly transition from being immature to being mature very quickly. If you have a bacterial infection, you are going to see a rise in the number of bands in the body. The body is trying to produce very quickly mature white blood cell counts, and as a byproduct of that, you see a sudden surge in these one step back immature white blood cells. Okay? So when we have an elevation in the bands, we would assume that the patient has typically some sort of bacterial infection. If the bands are very low, you see these rare things like typhoid or tularemia. Not so rare. We see that stuff around here every once in a while. PMNs is the percentage of mature neutrophils. This is the percentage of segmented nuclei or mature neutrophils. Normal value is about 45 to 70. This also is going to be high in bacterial infections. Severe stress can do it as well. So a lot of times trauma patients, just by virtue of having gone through some big horrific trauma, will have an elevated seg count temporarily. Not as high as someone who would have an infection, but I'll see it rise just by virtue of the body trying to fight something off or compensate for something. Eosinophils. Eosin stands for blue, and it's the way they stain blue under the microscope. That's where the name came from. Normal value, again, you shouldn't have a whole lot of these present in your body. When we see high eosinophils, oftentimes we're thinking of leukemias when it's exceptionally high, or if it's just a little bit elevated, parasitic kinds of infections. It also will get low with people on chronic steroid therapy. So transplant patients who are taking steroids, asthmatics who are taking steroids, are going to have lower values. Basophils, not so fully understood unless you're a hematologist or a doctor who specializes in leukemia. I wouldn't worry a whole lot about it. Again, it's very similar to eosinophils, where you see elevated levels or low levels. Lymphocytes, a little bit more important. These are things, this is a percentage of lymph cells in your body. Lymphocytes are particularly important in fighting off viral infections. So if I see somebody has a high lymphocyte count, I am thinking more that this is a viral infection as opposed to bands that I would think it's a bacterial infection. Okay? So this is how these things become useful. Reticulocyte count measures less mature types of red blood cells. Not a common test. We will do it again in oncology. It's very commonly done, but like in an emergency room setting or even a critical care setting, probably not looking at a reticulocyte count that often. All right? It's fairly hyper-specialized. SED rate, on the other hand, or erythrocyte sedimentation rate, it's abbreviated as a SED rate because that's a mouthful to say, is something that's done very frequently in an emergency room. And it's done because it normally is very low. And when it's elevated, it's an indication that there's some sort of inflammatory process going on. So if you think about all the disease processes that involve an inflammatory response, if we're trying to quickly shell that out and flush it all out, we can use this test along with a couple of others and say, hey, this patient's got a viral infection that's causing a lot of inflammation in their body. Any disease can cause inflammation. And so with chronic diseases, it's very common to see an elevated SED rate just because there's chronically a high level of inflammation going on in the body. So the SED rate will be high. So an indicator of an inflammatory process. That's the down and dirty of how I would explain a SED rate to somebody. So you will also hear people talk about when they look at this differential, they will talk about the patient having a left shift or a right shift. And it has to do, if you line up those mature white blood cells at the bottom of the chart that I showed you, if there are more of the kind that are on the left, the bands, that's a left shift. There are more on the kind of the right, like the lymphocytes, that's a right shift. So if I look at a differential, I'll see more bands, and I will say this patient has a left shift. That to me, in my head, means that that patient has a bacterial infection with a left shift. If they have a right shift, that's more lymphs. That typically means that they have some sort of viral infection. So that's how that nomenclature of left shift and right shift works. And you just have to get comfortable with that concept. Think about lining up all those mature cells, bands being on the left, lymphs being on the right, left shift bands, bacterial infection, right shift lymphs, viral infection. And it's not perfect, all right? But it's a good, quick, down and dirty way. You will hear people talk about that all the time when that result comes back. Oh, it looks like this patient has a left shift. Maybe they're septic. That's how it's talked about. All right, questions about the CBC and differential. You have a good idea now what, if somebody says what a differential is, could you give a street smart answer back to them about what a differential is and how you would use it, right? If I'm taking care of a trauma patient, I don't get a CBC with a diff. I care about the blood counts, so I'm getting a complete blood count, but I don't care about the differential. 5 days later, when they spike a fever in the ICU and now they're looking septic, I probably do care about that differential, so this time I'll get a CBC with a differential because I want to see very specifically what's going on with the immature white blood cells, okay? All right, coagulation tests. There's a whole bunch of them, and there's new ones coming out all the time, and there's drugs out there for which there is no test that do alter your coagulation. So this is becoming much more complicated than I had ever hoped it to be because of the drugs that are available to people to, quote unquote, thin their blood, okay? When we talk about coagulation tests, and don't fall asleep yet because I'm not going to read all of this back at you, coagulation tests look at the body's ability to clot. And there's two ways that the body clots. It clots via this extrinsic pathway and intrinsic pathway. The difference between the two is tissue damage and platelet effect. That's all I care that you understand about this. The bottom line is that it all comes together and makes a clot in the end. However it starts doesn't matter, all right? So I'm going to refer to some of these tests as acting on the intrinsic or extrinsic. I don't care that you remember that, all right? I might not even say it. It's just going to be on the slide. So the PT, or the prothrombin time, very typically is used to measure the effectiveness of Coumadin. So you can think of a lot of patients that are on Coumadin. That is the specific test that's done to measure the Coumadin's effect on the body. Normal pro time is anywhere between 11.2 and 13.2 seconds. It can also become abnormal in patients with liver disease. Your liver, amongst many of the things that it does, makes the bulk of your clotting factors. So if your liver's not working, you start to not make all those nice little things on that diagram that I showed you. And one of the things that specifically will affect is the patient's pro time. Also, if somebody has a vitamin K deficiency, actually a treatment for an elevated pro time is to give somebody vitamin K. It acts as an enhancement. So if their vitamin K level is low, they're not going to clot their blood readily, okay? That's why when people are on Coumadin, they have so many dietary restrictions. We don't want things that have a lot of vitamin K in them because it will counter the effects of the Coumadin. Coumadin levels are very hard to adjust to find what exactly is the right amount of drug to get the pro time where I want it to be, because in certain situations I want the pro time to be slightly elevated. For example, if I have a mechanical heart valve or even a biomechanical heart valve, I don't want the patient to clot quite as well as they would normally because blood likes to clot on things that aren't natural in the body. So we give them Coumadin to slightly elevate their pro time. I don't want it to be to the point where they're going to have a spontaneous bleed, but I want it to be usually 1.5 to 2 times normal, depending on the type of valve that's used, as one example. All right? So they're on this Coumadin, and now they're told that they can't eat this, they can't drink that, they can't do this, and it's because those things alter the effects of Coumadin. Green leafy vegetables has a lot of vitamin K in it. I'll get somebody on a nice level of Coumadin that gets their pro time where I want it to be, and now they start eating green leafy vegetables, and it negates the effect of the pro time. All right, so they're going to need more, or the Coumadin, excuse me. They're going to need more Coumadin all of a sudden. So it becomes very difficult to regulate these people. That's the test that's used. The INR is also a very common test, and most hospitals today will, instead of reporting a PT, will report an INR. It stands for International Normalized Ratio. All right? It's a much better test than the PT is. It's better averaged over a large population. So in fact, I gave you this example of the patient with the mechanical valve and what their PT is. The test that they actually test nowadays is the INR, because it's a much more standardized test across the board. Tells us the same thing, has different normal values, but it's telling us the same thing, and it's a much better test. More specificity, as an example, and just a better measurement. So the INR of a person not receiving any anticoagulants is going to be about 1. People who are receiving Coumadin, the goal, and again, this varies a little bit depending on what we're trying to accomplish with that blood thinner, but generally we want it to be somewhere between 1.5 to 2.5 for a measurement. And that would be an acceptable normal value. For example, if a patient with a mechanical heart valve's INR gets to be 1, they are at a very high incidence of clotting off, having a thrombus form on that valve, or having the valve fail altogether. So this stuff becomes very important. PTT is another test. It detects coagulation disorders on the intrinsic pathway, so where the platelet branch of the clotting cascade. Normal value for PTT is 22 to 34.1 seconds. It's the same for men and women. The most common reason why the PTT is going to get elevated in the hospital setting, or even at home, if the patient's getting heparin at home, is by the use of heparin. Heparin directly affects the PTT, the partial thromboplastin time. So with enough heparin in the body, it's going to prolong or elevate the PTT. And we may want to do that, again, for the very same reason why we wanted to prolong somebody's bleeding with Coumadin with a heart valve. In the hospital, we might use heparin, because it's a lot easier to titrate the heparin than it is the Coumadin in a really sick patient. So then we would have to use this test to follow the effectiveness of our heparin. All right? Low values, generally we don't worry too much about low PTT. It's usually not even something that's seen very commonly. More commonly, what you see is an elevated PTT. So typically it's someone on heparin. It could also be someone in liver failure where all of their coagulation factors are not being produced. The treatment for that reversal of heparin is a drug called protamine. So if somebody accidentally got an inadvertent excess amount of heparin, or maybe they had surgery where they wanted them to get an excessive amount of heparin, the way to quickly reverse the effects of heparin is to give protamine. And there's actually a newer drug out there, but it's not in your book, and I don't think we know enough about it right now, that is used to treat the effects of heparin-induced elevation in your PTT. The blood product that can be used to lower someone's PTT more towards normal is fresh frozen plasma, or FFP. FFP contains a lot of the clotting factors that are specifically not present when heparin is inside the body, circulating around at a sufficient level. Right? Fibrinogen is another part of the clotting cascade. The one thing about the clotting cascade that I just had the slides, I didn't have your book, and I'm not sure that the book goes into this or not. The one thing to understand about the clotting cascade is it's like a ladder. And if one of the rungs of the ladder are missing, it prevents anybody from going on down any further. So what do I mean by that? If one step or rung in the ladder is missing in the clotting cascade will stop there, and the clot formation will cease until you replace that one level. It's very, very specific how the clotting cascade works. One step is dependent on the other, or one rung is dependent on the other. So fibrinogen is one of those steps in the clotting cascade. If it's missing, the blood is not going to have the ability to clot as well as it might. Fibrinogen forms fibrin during the blood coagulation, specifically helps to bridge and connect platelets together. It's often depleted in massive hemorrhage. Normal levels are about 170 to 494 milligrams per deciliter. The blood product that is specifically used to correct a low fibrinogen level is cryoprecipitate. It looks a lot like FFP, but it's a very different sort of thing. Doesn't usually come in the same volume. And generally we get concerned about treating a low fibrinogen level. If somebody's actively bleeding and their fibrinogen level is less than 100, we're interested in probably giving that patient some fibrinogen. And you will see, like in massive trauma, even if somebody's not bleeding, maybe somebody has a severe traumatic brain injury, one of the things that happens in severe traumatic brain injury is that it disrupts your clotting cascade. These patients can go into DIC simply because of the insult to their neurologic system. And one of the things that is often seen is that their fibrinogen levels get quite low. Actually, the mortality of somebody with a traumatic brain injury whose fibrinogen level is less than 100 is very much higher than it would be if their fibrinogen was normal. There's some statistical information. There are a whole bunch of other factors that are part of the clotting cascade. There's even some electrolytes that are part of the clotting cascade. Calcium is an example of one of the rungs on the ladder. Suffice it to say that these factors all participate in the clotting cascade. And when somebody has hemophilia, for example, they're missing one of the rungs on the ladder, it causes their blood not to clot, right? Just by missing that single factor. So that's a good example of, if you're trying to remember how the clotting cascade works, think of somebody with hemophilia. They're missing one particular factor, it prevents their blood from clotting. It only gets so far in the clotting cascade and then it will stop. Replace that factor, the blood will continue to clot appropriately. Okay? Other sort of tests that are done, usually in critical care, not so much in the emergency room, fibrin split products, or FSPs, you'll see it reported in the lab. This measures the amount of clot breakdown, and it's a test that we do specifically when we're looking to see whether a patient has DIC. Are you all familiar with what DIC is? I threw that acronym out. And disseminated intravascular coagulopathy. Another term for it is consumptive coagulopathy. Your body uses up the clotting factors faster than it can make them, and it's usually going on when there's bleeding going on. So the body cannot keep up with making clotting factors sufficiently to stop bleeding because it's just losing it as fast as it's making it, or even faster than it's making it. That's what disseminated intravascular coagulopathy is. Many things can cause it. Severe traumatic brain injury can cause DIC. The mechanism of why that happens isn't even really well understood. Why does something to your head cause your clotting system to go out of whack, right? Obviously, if you're hemorrhaging and your body is trying to stop the bleeding, you're going to use up your clotting factors faster than your body can produce them. We use fibrin split products as a way to measure the amount of degradation of fibrin. If it's really very high, it's telling me that the body is breaking down faster than it can actually make and keep a clot formed in the body. D-dimer is another one of those tests. It's generally part of a DIC panel that will be ordered to assess the patient for how severe their disseminated intravascular coagulopathy is. It is going to be elevated as well in situations where patients are bleeding, or, interestingly enough, anytime a patient has a large clot that has suddenly formed in their body, their D-dimer it becomes elevated. So it's used sometimes to help in the diagnosis of pulmonary embolism or DVT. Thrombin time, not that commonly done. It's basically times how long it takes blood to clot. They put the blood on a slide and start a timer and check it out and see how long it takes before it coagulates, all right? It's done in some very hyper-specific situations with specific types of coagulopathy, not going to be part of what you're going to be doing in an emergency room or in the back of a rig, that's for sure. There's an actual bleeding time. There's one of those. That's really measuring it right off the skin. This is something that's done in the lab. But again, we're looking at, this is, they've done every other test in the world. This patient still has a bleeding abnormality. Then they start jumping to those kinds of tests. So not something that is going to be something you're going to see every day, every month, maybe even but once a year is the reality of that. All right, any questions about the clotting factors? There are other tests that are out there. We're going to start using this unfractionated heparin level instead of PTT when we're titrating our heparin infusions. So there's other tests that are out there. Probably not going to be exposed to them right away, but know that all the time we're always looking for better ways to quantify and qualify these results in the human body. Okay? All right, chemistries. We're looking at specifically electrolytes. The DIC panel that I mentioned is oftentimes considered a chemistry, but also looking at kidney function tests, liver function tests, how the body metabolizes glucose, how the body metabolizes lipids, and then probably most important to all of you working in EMS are the things that are run to determine cardiac injury. So if somebody's having an acute MI. So we're going to take a look at those things. Sodium. Sodium level is a very common electrolyte. It's usually part of any basic chemistry exam that's done. In most people, it's going to be normal. When you do see abnormalities in sodium levels, what you need to understand that most of the time what that is, it's related to volume status. So if someone's dehydrated, their sodium level goes up because there's more concentration of sodium in their bloodstream. If the patient is overhydrated, like in CHF, or they've got too much IV fluid, their sodium level is going to be low because it's diluted. So any abnormalities in sodium, your first thought is either they're overhydrated or they're underhydrated. That's a basic rule of nephrology that they talk about. Having said that, there are circumstances in which a patient isn't dehydrated or isn't overhydrated that they will have an abnormal sodium level. What you should know about the sodium level is if you don't know how long it's been significantly abnormal, and the more abnormal it is, sodium is one of those levels that we don't try to correct quickly. All right? We're going to probably correct sodium over 8, 12 to 24 hours. Because what happens is if you correct the sodium level too quickly, because it's related to fluid volume most of the time, it can actually cause cerebral edema if we try to over-aggressively, very quickly correct someone's sodium. So while I would be concerned about somebody that was very hyponatremic, a low sodium, I would know that I'm going to need to gradually correct that situation. Because if I correct it too quickly, I can actually cause a very significant problem in the patient, which is cerebral edema and possible herniation. Okay? So we see it. We know that most of the time it's related to volume status. The subtle high and low of sodium is related to volume status. When it's excessive, I have to sort this out a little bit more, and I need to know that I can't just quickly correct the sodium. If someone's potassium is low, I can give them some potassium and in a half an hour be well on my way towards correcting it. Nothing bad is going to happen to the patient. That's an appropriate thing to do. With sodium, we have to be very careful about how quickly we correct it because of where it is inside and outside of the cell at the point where it's abnormal. And by giving somebody a lot of sodium or a lot of fluid to try to correct it can cause that fluid to shift inside of the cell and cause cerebral edema, specifically the brain cells. Other causes of low sodium can be vomiting, diarrhea. If somebody has been laying in an ICU for a couple of days and they've had their NJ tube to suction and they've been sucking out 400 or 500 cc's every shift, that can be something that could cause the patient's sodium level to become low. That's not part of this idea of being overhydrated or underhydrated. It's excessive losses from the GI tract. Diuretics can also have that, cause that. And then some sort of funky diseases like Addison's disease and kidney problems can lower the patient's sodium level abnormally. The kidney excretes more sodium than it retains abnormally. That's going to cause the sodium level to go down. The kidney doesn't excrete sodium. That's going to cause the sodium level to go up. Potassium. This is one we always need to focus on in critical care, certainly in an emergency room, certainly in the back of an ambulance. All right? This measures our serum potassium level. Under normal circumstances, and this is one of those things that I was like, what? That's not what I know as a normal potassium level. And it's because of the unit of measurement that's used. How any of you familiar with a normal potassium level in the institution where you work? Yeah, it usually doesn't get much higher than 5. Certainly not 100, and it's because of the unit of measurement that's used. That's where when I started out, talked about you need to know what unit of measurement you're working with. And this is a great example of it, because I would look at this and I would just about pass out. The patient would be dead if their potassium was that high in my unit of measurement, all right? It's milligrams per deciliter. So yeah, usually we don't want to see it less than 3 or more than 5 in my unit of measurement. But I guess for the test, if somebody asks you what a high potassium is, just kind of familiarize yourself with that level, knowing that I don't know of any hospital in our communities that uses that unit of measurement. Other parts of the country, that may very well be, obviously, but not around here. Potassium is predominantly an intracellular ion, all right, an electrolyte that lives inside of the cell. All right? If I measure your serum potassium, it's relatively low, 3, 4 milligrams per deciliter. If I measured it on the inside of the cell, it's going to be much higher than that. I think it's like 14 or 15 milligrams per deciliter. All right? When you're measuring the serum potassium, you're measuring the amount of potassium that's in the liquid part of the blood, not what's in the cell. All right? Understand that. As the measurement of the potassium in the serum starts to go down, it's going to start to come out of the cell. The body's always trying to balance the levels of all these electrolytes. That's when we get concerned, because what's dissolved in the liquid part of the blood is what is bioavailable to the muscle cells. And what happens when you don't have enough potassium floating around in your body, not inside the cells, but floating around the body, is you can have cardiac electrical abnormalities, you can have muscle weakness, tremors. The one we worry about the most is cardiac electrical arrhythmias or dysrhythmias if your potassium gets low. And it certainly is one of those electrolytes that I can relatively quickly correct. Usually we replace potassium no faster than 20 milliequivalents in 30 minutes. We would never want to quickly correct someone's potassium. We need to do it over time because the potassium needs a chance to go from the liquid part of the blood as it's going into the IV to get itself back into the cell. And if I force a whole bunch of potassium into the bloodstream and raise the bloodstream level, that's when it can have toxic cardiac effects predominantly. What it will do in those circumstances, a high potassium, what does it do to the EKG? You get peak T waves. What else happens? What happens to the QRS complex? It gets wider. And you end up getting this thing, it's called a sine wave, and it just looks like a big slurred bell curve going across the monitor. That is the direct effect of hyperkalemia. all right, high potassium in the bloodstream. Hypokalemia, generally what you see are types of ventricular ectopy, PVCs, runs of VTAC. Those are the kinds of things you'd see with low potassium. Things that cause low potassium values, diuretics are probably the most common situation. Large steroid doses. It's also associated with metabolic alkalosis. I wondered where that slide went, and it was because the information was right here. The regulation of potassium is also very much controlled by your body's pH. So we've already established that most of it lives in the cells, some of it lives in the serum, right? As your body becomes acidotic, pick a reason, for whatever reason, that acidosis, that lowering of the pH, causes the potassium that is in the cell to leak across the cell membrane and now be present in the serum. So if somebody's very acidotic and I measure their potassium, very commonly it's very elevated. Their serum potassium is very elevated. And that's what actually happens to you when you get really acidotic. You shift potassium out of your cells and you start getting peak T waves and you widen QRS, and the next thing you're in a systole, all because of the pH. All right? They don't have an excessive amount of calcium in their body. It's shifted where it is. It's supposed to be in the cell. Now it's outside of the cell. Very much dependent on the pH. So acidosis, more potassium leaks into the serum, and you can see the negative effects of hyperkalemia. On the flip side of that, if I make somebody alkalotic by hyperventilating, overventilating them, too fast of a respiratory rate, and I shift their pH to a higher level, that's going to cause potassium that's in their serum to shift into the cell. So when I measure their serum potassium, simply because they're alkalotic, their potassium in their serum is going to be lower because now I put more of it in the cell. Direct effect of pH on where potassium lives in the body. It's important to know because we're always messing with people's pH or finding patients with abnormal pH, right? You see a patient in the field with diabetic ketoacidosis. They're acidotic. What's their pH? It's very low. What's their serum potassium if you measured it? It's going to be very high because they're acidotic at that moment in time. I can correct that hyperkalemia or high potassium simply by reversing their acidosis. I don't have to give them drugs to get rid of potassium. I just give them drugs or treatment to lower or raise their pH and shift that potassium back into the cell where it belongs. Okay? If that's what the problem is. Now, you can have an elevated potassium that is not related to your pH. I'm going to think of kidney failure. Somebody goes into acute kidney failure. Your kidneys are responsible for constantly maintaining this balance of intracellular, intravascular, and what's put out in your urine. If your kidneys shut down, you're going to accumulate potassium in your bloodstream. It's nothing to do with pH at this point in time. And that I can't really manipulate. I can manipulate the pH a little bit. I could make them a little bit more alkalotic. But in that situation, we're going to give the patient drugs to help get rid of potassium other ways. It can be elevated in kidney failure. It also can be seen in decreased pH or acidosis. In fact, if I give somebody enough normal saline very quickly, and I'm talking like 6-7 liters of normal saline, if you ever get a chance when you're sitting somewhere, grab a bag of normal saline off your shelf and look at the pH of that solution, it's very acidotic. So if I give somebody a whole bunch of normal saline very quickly and make them acidotic, I can do a couple of things. I can raise their sodium level too fast, I can raise their chloride level too fast, and lower their pH, which is going to drive their potassium out of their cells and make their serum potassium elevated. So we actually are very careful nowadays how quickly we give somebody sodium or normal saline. young, healthy people with good kidneys can sort that out pretty quickly. But critically ill people with renal failure may have some difficulty, and we need to be careful. We have sepsis protocols now, right, where we give the patient so many liters of normal saline to raise their central venous pressure so that they're perfusing well. Most of those protocols switch from normal saline to lactated ringers, which has a more normal pH once you get past 10, 12 liters of normal saline because of the acidosis effects, acidotic effects of the saline and the introduction of more sodium and chloride. Low values are seen, low chloride values, again, vomiting, gastric NG suction, excessive diarrhea, diuretic use. Kids get chloride and sodium abnormalities much quicker than adults do from a bout of vomiting and diarrhea, for example. So if you're taking care of a child who's been sick for a couple of days with vomiting and diarrhea, not being able to keep much in or down, it's important to look at their electrolyte levels, particularly their sodium and chloride, because they can get really out of whack very quickly, much faster than an adult would. Bicarb measures the serum bicarbonate in the body. Normal is 24 to 30 milliequivalents per liter. Your kidneys are responsible for making bicarb. So if you are in kidney failure, you will have a low bicarb level because you don't have kidney function to make bicarb, all right? So if I'm taking care of somebody in renal failure, I would expect their bicarb to be a little bit on the low side. The body compensates in other ways. If the patient is not in renal failure and their bicarb is low, I have to really think about what's causing their bicarb to be low. So what makes your bicarb low? It's an excessive amount of acid production. So bicarb is the buffer that buffers all the acids. So think of anything that could make your patient acidotic. That's going to chew up bicarb as the body tries to neutralize the pH, and your bicarb level will be low. All right? Generally, we don't treat a low bicarb. Years ago, some of us are old enough to remember this, where we would, as a part of a resuscitation, give the patient a couple of amps of bicarb to reverse the acidosis that was going on. We don't do that now. We know that it's actually harmful to do that to a patient. We know that most of the reason why a patient is acidotic in a cardiac arrest situation is what? Why are they acidotic? Because they're not breathing, right? It's their CO2 that's drive their CO2 down. That's going to correct their acidosis. Years ago, I don't know, we knew that, but we didn't pay attention to that. We would give people tons and tons of bicarb, and that can be actually very harmful to patients, so we don't do that anymore. Other reasons why the bicarb can be low, a lot of the diuretics will excrete excessive bicarb from the body, so patients get a low bicarb. Consequently, they get a little acidotic because now they don't have as much neutralizing agent in the body. Low values, base deficit. We'll talk about that in I think it comes up in a couple of slides. Metabolic acidosis, as I just mentioned. Excessive bicarbonate consumption or loss, like in different types of kidney dysfunction. And an increase in the serum sodium level. So your bicarb goes down as your chloride level goes up. I said sodium, I meant chloride. Magnesium has become probably as important as potassium is. And if I was transporting a critically ill patient, these are the two labs that I would probably most want to know about. What's their K and what's their magnesium level? Because one of the things that could happen to me that I might need to do something about on transport is they could have an arrhythmia. Magnesium is the other drug, or other electrolyte, that is very commonly low in critically ill patients. As a matter of fact, 60 to 65% of untreated critically ill patients will be hypomagnesemic or have a low magnesium level. Normal magnesium, very narrow range. In my world, I think of it going up as high as 2.2, but your book says up as high as 1.9 is normal. When can you have excessive low values or excessive hypomagnesemia? Kidney excretion, excessive kidney excretion. Again, GI loss, sucking 5 days worth of stuff out of somebody's stomach, that's going to make their magnesium low. It is also seen along with low potassium. So low potassium, you could anticipate that the patient's magnesium is going to be a little bit low as well. The big concern for us in the emergency room, critical care, is that when someone's magnesium gets low, they can have dysrhythmias. What's the dysrhythmia that's torsades? Is the lethal arrhythmia that you can get to if your magnesium is excessively low. But before that comes runs of VTAC, lots of PVCs. So knowing what someone's potassium and magnesium, and again, magnesium is one of those things that can be relatively quickly treated. I can give somebody a couple of grams of magnesium in 30 minutes and get their magnesium level up to where it needs to be to suppress that arrhythmia. So that's one of those tests that I would be checking out of the boatload of things that you have in front of you to look at. That certainly would be one of them. Hypermagnesemia is really pretty rare to see someone with an elevated magnesium level. It can be seen in some types of renal failure. Most commonly when it's seen, it's somebody has ingested an excessive amount of magnesium. So some of the antacids that people take have a high level of magnesium. They overdose on that stuff, and their magnesium levels can be excessive. Kind of a fun fact, Dead Sea water poisoning. Like if you ingest water from the Dead Sea, it's very, very high in magnesium you can get. I don't think we're going to run into that around here. But a little fun fact, Trivial Pursuit. Calcium. Calcium is measured two ways in the body. It's measured as a total serum level, and it's measured as a free-floating, bioavailable level. The first one that we'll talk about is the total serum calcium. Understand that calcium, most of it is bound to something else. It can be bound to drugs, it can be bound to albumin, other proteins in the body. So when I measure someone's total serum calcium, I'm measuring what's bound to something and what's free-floating available to the cells. Okay? Normal value 4.3 to 5.3. I can see high calcium values in dehydration, thyroid problems. Certain malignant tumors will cause the calcium to become very high. Also, some diuretics may do that. Low values are a little bit more common. We can see that in severe malnutrition, chronic renal disease, patients with acute pancreatitis or chronic pancreatitis. And then it can also be low falsely. So when we're looking at patients' total serum calcium level, we also always want to know what their albumin level is. All right? If their albumin level is low, that would explain why their total serum calcium is low. This becomes a very difficult test and probably not that useful to EMS workers or people in critical care or in an emergency room because there's a lot of factors that go into what make a total serum calcium normal. What we care more about in critical care, and what I would, again, another one of the tests that I would want to know that it was done and what the result was before I got into the back of a rig with a patient. I would want to know what their free calcium level is. It's most commonly understood as the ionized calcium level. That's the same thing as saying free calcium, ionized calcium level. That is what's bioavailable to the cells. That's what's going to make the difference on how well someone's heart functions, what kind of arrhythmias they may or may not have. It's that bioavailable. And actually, the ionized calcium is also one of the steps in the clotting cascade. So if it's missing, if it's low, it can affect people's bleeding time, actually, if I let their ionized calcium get low. It's a pretty important electrolyte. Normal values in the book range 4.64 to 5.28 in the way they measure it. The way I measure it, it's not quite that high. Again, you know where you work. High values are seen in a whole bunch of things, most of them sort of bizarre cancers or tumors or metabolic syndromes. Not something you're just going to encounter every day. Low values are much more common, and critically ill patients, again, this is an electrolyte that oftentimes can get quickly abnormal and start to cause problems for patients. So I would want to make sure it's okay before I got into the back, took this patient on a long road trip or whatever else you're doing, get on the back of a helicopter and flying this patient somewhere. I'd want to know what it is. It can very commonly become low in a trauma patient from getting massive amounts of blood products in the resuscitation. So if they're bleeding and they're giving them, they have the level 1 or whatever device they're using hooked up, patient's bleeding and they're giving them unit of blood after unit of blood after unit of blood, that can actually cause your ionized calcium level to go low. A lot of people don't know that. They forget about it. They don't do it enough. So before I would transport a trauma patient that I knew got massively resuscitated, I'd want to know, did we check their ionized calcium level recently and what was it? And if it was low, did we treat it? Because get them in the back of an ambulance, if it's low, they're going to continue to bleed and there's not going to be a whole lot I can do about it. Because again, it's one of the steps in the clotting cascade. Take it out, blood doesn't clot. So why does this happen in massive transfusion? Because in the blood bank, inside of the bag of blood, they put a chemical, a drug. It's called citrate that actually binds calcium. So it removes calcium, ionized calcium, from the clotting cascade of the blood in the bag, and that it won't clot when it's sitting on the shelf. All right? If I give a patient a unit of blood, there's not enough citrate in there for it to affect their body, so it's not a big deal. Their liver metabolizes it. It's all good. They don't see any net effect of it. If I give somebody 25 units of blood in 15 minutes, I very quickly overload their body with this citrate, and it has the same effect on their blood as it did in the bagged blood on the shelf. It starts to bind their ionized calcium, and it pulls out calcium from their clotting cascade. So I'm there resuscitating the patient like crazy with blood, all in the same time making their ionized calcium level low if I'm not paying attention, and they're just going to keep bleeding. So if they've got holes, it's not going to stop. So part of a massive resuscitation protocol always is, in addition to checking what their CBC is checking what their ionized calcium is. And if it's low, giving them some calcium to bump up their ionized calcium level in their bloodstream. So far we've got, I want to know what my patient's CBC is. I'll maybe want to know what their differential is if I think they might be sick, septic, okay? I certainly want to know what my sodium is, but if it's excessively high or low, I probably can't do a whole lot about it acutely. I just would need to monitor the patient and think about correcting this over the next 24 hours. I've got potassium, can cause acute problems, dysrhythmias being the big one. If it's low and or high, I can correct it relatively quickly. Usually within an hour or two, I can get somebody's potassium level back going towards normal without any bad outcome. Magnesium and then calcium. So those are the big ones that out of all of these things that we've talked about. And then the clotting factors. Thinking about, that gets a little bit tricky, right? Because which of them is going to be elevated? Why is it elevated? Is it elevated in a manner in which I expect it to be because of a drug they're on? That stuff sort of becomes a little bit more tricky. But certainly if somebody has an extremely elevated INR, PT, PTT, I would want to know that and they're bleeding, I would want to be thinking about what I'm going to do to correct that now, during transport, and when I get that patient to wherever it is that they're going, all right? And you learned, if you didn't know, the way that we can correct those clotting factors oftentimes is just by giving somebody FFP and cryoprecipitate, okay? Because those clotting factors are contained in those blood products. Phosphorus. This one gets tricky. It can be abnormal in kidney failure and in thyroid abnormalities. It's not something that I would say you need to be acutely hyper vigilant about as a paramedic. We certainly do correct it if it's low, give drugs to make the level go down if it's elevated, but it doesn't generally cause an acute problem for us in the moment. Okay? It can if it gets out of hand and we don't pay attention to it for a couple of days. But certainly, it's not that commonly abnormal in most patients, and if it is a little bit off, it's not going to have any immediate bad outcome for the patient that I'd need to be obsessing about. It's difficult to give. A dialysis patient would have a very high phosphorus level. They're probably going to be on, there's other drugs out there now. The one that I'm most familiar with, and I haven't thought about this in a while, is Amphigel, the antacid. It binds phosphorus, and you excrete it in your stool. So patients will be prescribed Amphigel to help keep their phosphorus levels down because of the way that it works through your GI tract. Okay? Yeah, very definitely. Taking care of dialysis patients, phosphorus abnormalities are very common. They're usually on something to help keep it in check. Probably still going to be elevated, though. Anion gap. An anion gap is a measurement of the difference between the positive ions and the negative ions in the bloodstream. And we're looking particularly at the electrolytes that we've talked about so far. It's a mathematical formula. You used to know how to have to do this, but now the computer tells you what the anion gap is, so you don't have to do the math. But you can see the mathematical formula that's used to determine an anion gap. So when you see the result in the computer, know that it used this formula to do so, and which electrolytes were involved in. And there's a couple of different variances on this formula, but this is a reasonable formula. So you could figure out someone's anion gap by knowing what their electrolytes were, or you can let the computer do it. And I prefer to let the computer do it. What it's used for is to determine whether the patient has an acidosis or an alkalosis, and what the cause of that is or may be. So if somebody has an increased gap, so greater than 14, that is indicative of some sort of acidosis. So like patients with diabetic ketoacidosis, they have a very high anion gap. All right? The cause of that is their diabetic ketoacidosis. Okay, so to normalize their anion gap is going to be just simply correcting their diabetic ketoacidosis. And I can measure how well I'm correcting and how well corrected they are from their DKA by repeatedly measuring their anion gap. Once it gets back to normal, I know that I've got the patient back into normal glucose metabolism. So that's how that test is used. It's also used in toxicology. So certain poisons that people ingest will cause them to have an increased anion gap. Don't write this down. Do not quote me on this, but I'm going to use it as an example anyway because I think I'm right. Aspirin overdose. It's going to cause an increased anion gap. It's acetylsalicylic acid. A very high and very large anion gap is going to mean a lot of aspirin is on board. All right? Although I can measure salicylate levels as well. So it's just going to kind of give you an idea of where you are and are you correcting the situation. A decreased gap, so a narrowing, so less than 12, is indicative of alkalosis. Again, if somebody's alkalotic, I would expect their anion gap to be low. The treatment is going to be to treat the underlying cause of what's making them alkalotic. All right? But that's how an anion gap is used. An anion gap is primarily used in the management of diabetic ketoacidosis to tell you that you're moving in the right direction with correcting their glucose metabolism. All right? It's also an indication of the severity of their ketotic state. Right? If they come into the ER and they're in DKA, and if someone says, well, let's get an anion gap on them, and it's at 24, 26, well, this patient's really in trouble. What's their pH? Let's get them to the ICU. All right, as opposed to, they're in DKA, but their anion gap isn't that elevated. We can probably simply correct this diabetic ketoacidotic state here in the emergency room and maybe watch them for a couple of hours. Okay? So that's how that test is used. Questions about that? All right. Kidney function tests. I'm just going to hit the most common ones. There's a whole bunch of them. BUN, blood urea nitrogen, measures the amount of urea nitrogen in the blood. Pretty obvious. Has a normal value of about 8 to 15 milligrams per deciliter. It goes up when your kidneys can't get rid of it. All right? It's produced by a number of things in the body. And when the kidneys are unable to get rid of it, it accumulates in your body. So patients in acute renal failure, you will see their BUN go elevated. Patients in chronic renal failure will have an elevated BUN. If they're on dialysis, we probably keep it, more towards the normal side of things, but it usually runs a little bit on the elevated side. Also, if you're dehydrated, your BUN will become elevated. Concentrated is the way to think of it. Low levels of BUN, most common if patients are overhydrated. If they get too much IV fluid resuscitated, I could look at their BUN and it's going to be low. Not anything I'm going to do about that other than let the patient diurese a little bit or help them diurese. Also, if antidiuretic hormone is excessively secreted, so your body is told to not produce urine and more fluid is retained in your vascular space, same net effect. Your BUN is going to become low. Creatinine is probably a better test of kidney function or renal function. Because BUN can be so much affected by your overall hydration status, you're either overhydrated or underhydrated, most of the time we look to the creatinine level to really say, hey, this patient's kidney function is deteriorating. Okay? When we're taking care of them in the ICU, I'm more concerned about what their creatinine is on a daily basis. I'm taking care of a kidney transplant patient, and I think that they might be in rejection. I would be watching for their creatinine to rise. So it's much more specific, and it's not as affected by being overhydrated or underhydrated. Does that concept make sense? As does the BUN. So it's a little bit more of a specific test when you're looking at kidney function. So high values are seen in kidney disease or nephrotoxic medications, all the antibiotics that cause nephrotoxicity. We see that by watching the patient's creatinine go up after they are on the med for a couple of days. Would be an indication to decrease the dosage of that medication. Low values of creatinine, low muscle mass, so patients that are in a chronic, nutritionally deprived state may have low creatinine levels. It's produced from muscle breakdown, muscle cell breakdown. So if you don't have a lot of muscle mass in your body, you're not going to be producing a lot of creatinine. Questions about that? Those are the main ones. If you're a nephrologist or you're working for a nephrology clinic, there's going to be doing a whole lot of other lab tests, specifically more so looking at urine samples, looking for the electrolyte measurements of what is making up the urine. Because there are, just like there are normal serum levels of these electrolytes, there's normal urine electrolyte levels, and they're quite different. So the cardiac enzymes. This has shifted probably more than almost anything since I've been in critical care. How we use these values and what was available to us years ago and what we really look at now to decide whether or not somebody is actually having an acute cardiac event. The most common one that was originally out there is the CK, or creatinine kinase. It can be subdivided, just like our CBC could be divided into the differential. I can do the same thing with the CK, subdivide it down into what are called isoenzymes, or smaller little breakdown enzymes underneath there. The most important one is the CKMB, because that's going to be the one out of all of these that is most specific to myocardial cells. All right? We can see high CK levels, though, in a variety of things. And that's why this is not the most specific test for determining whether or not somebody's having an acute myocardial infarction. All right? It used to be. It's just not anymore. It can be seen in any muscle disease. I can see someone's CK go up from excessively exercising. You know, people that do these triathlons and these Ironman, if you measure their CK levels after they do that, they're very high. And that's just because of the excessive exercise. Their body is producing it faster than their body can get rid of it. IM injections can cause that. Other serious healthcare issues that can cause an elevation in the CK, shock can cause that to happen. Cells rupture and release their enzymes into the bloodstream. It becomes measurable. Certain tumors can cause an excessive creatinine kinase level. So as you can see, it sort of becomes this really non-specific test unless you're specifically talking about the isoenzyme MB. All right? Myoglobin is another test that is not completely specific to the heart, but we have started to use it on a more regular basis to measure whether or not, help us determine whether or not a patient's having a myocardial infarction. Normal in this way of measuring it is 50 to 120. Oh my gosh, I don't even know what that stands for when I look at that. I should have looked that up. I didn't. Per deciliter, it's not how I would measure it. So that's why I was like, oh, wait a minute, I didn't even think about that. High levels are seen in myocardial necrosis. So if somebody's had an acute MI, muscle cells have died, we're going to see an elevation in their myoglobin. All right?
How would you measure it?
Blood. How would I measure it? Oh, in grams per deciliter, and I would have to look at the normal reference values that are displayed in the computer at my workstation. It's not something that we're doing all of the time. That's the beauty and the beast of having computerized lab resulting, because I have no reason to remember these normal values anymore other than unless somebody tells me they're going to test me on it, because the computers show you what the normal levels are, right? Low levels, not clinically significant. High levels, indicative of myocardial necrosis. So CKMB, we sort of talked about that already. That's that isoenzyme. That is the myocardial band. If it's greater than 12 units per liter, that is probable for an acute myocardial infarction by most people's understanding. High levels of CKMB are seen in myocardial injury damage. Again, low levels, not significant. I'm not going to, it could be 0 and I'd be just fine with that. Troponin probably is the most commonly used enzyme to look specifically at the heart. Normal levels, very low levels in the body. We tend to get concerned about, again, depending on your lab system, what's called back as abnormal versus what is called in as a critical level. Varies a little bit, but we want to see that troponin level less than 0.2. If it's above that, we are highly suspicious that this patient has had or is having a myocardial infarction. Again, high levels are seen in myocardial necrosis. So this is a test that is specific to myocardial cells. This is a useful chart that you'll get when you get the handouts for this. It's something that I added. It just shows what happens to these various blood levels in the body over time after a myocardial infarction, and what has helped us shift which tests we get when a patient shows up in the emergency room, right? I don't want to see a test when somebody comes in with 20 minutes of chest pain that's going to take a day to peak out as elevated. I want to pick the test that's going to quickly become elevated. Does that concept make sense? So if we look at what becomes elevated very quickly, we see that the CKMB with reperfusion, meaning I did something like a procedure, a cardiac cath, balloon angioplasty, some TPA that opened up that coronary artery, all right? Let the blood into the heart. What happens when you do that is you have this shunting of all of this CK and troponin that's hanging around in the myocardium. Now that it's well perfused, it gets into the circulation. So we see a rise in the serum level of it. And just take a look at which tests rise the quickest. We have the CKMB, and then we have the troponin, and both of those are with reperfusion, what I just described. Without reperfusion, so acutely in the emergency room, we still have the CKMB and the troponin peaking out pretty quickly. The disadvantage of troponin, for example, is that let's say 2 days in, this patient starts having chest pain again. Oh, I'll draw some cardiac enzymes. Well, guess what? My troponin level is still going to be elevated from the first infarction that they had. I may not see the jump up unless it's a really high troponin level. So each of these tests has an indication for a specific use in time. And it's based on how quickly the body levels of that enzyme rise in a lab test. Okay? So you can sort of see how that operates. We've gotten much better at this, and they're always looking for new ways. Because, man, wouldn't it be great if I could get a lab test that could measure, and there are things that are out there. I can measure, that are going to start to rise within half an hour of somebody having chest pain to help us confirm what's going on. We take care of a lot of patients with chest pain, right? That fortunately, most of the time, it turns out to be not cardiac chest pain, but we spend a lot of time, money, effort, energy from EMS all the way through the emergency room, sometimes even into the cath lab, only to decide that this isn't a cardiac event, all right? And it's because none of the tests, like that very first slide that I showed you, that no test is 100%. So I have the physiologic test of the 12-lead EKG, I have all these blood tests that I can do, I have all the symptoms that the patients describe to me, and that is how I ultimately decide whether or not this patient needs a cardiac cath or not. All right? It's not just the 12-lead, it's not just the labs, because the labs can be out of whack for other reasons. Right? It's a constellation of all of these tests that help us make that decision. And understanding how this functions is also important, because 2 days later in the ICU, if I draw this guy's troponin level, even though he's fine now, it's still going to be elevated because it's still circulating in his body. It doesn't mean anything anymore to me, like it did when he presented in the emergency room. Another very common test that is a cardiac enzyme used in a different way is the BNP level. B, natriuretic peptide. No one says that. They just say the BNP level. And be careful because there's a BMP and a BNP. BMP stands for Basic Metabolic Panel. It's a series of chemistries and labs that we get on a patient as a part of a routine workup in the emergency room. We'll get a BMP on them. BNP is very specific. It's looking at, your body produces this peptide when the heart is under stress. In particular, it's very specific to congestive heart failure. So if a patient has these acute symptoms of shortness of breath, they have a history of COPD and they have a history of CHF, we can draw this test and determine pretty well that this is the cardiac failure component rather than a COPD exacerbation. So that's how the BNP is used. A COPDer will not have an elevation in their BNP. Somebody who's short of breath for a couple of days and shows up in the emergency room who has an elevated BNP, that is somebody who's probably having an exacerbation of their CHF. So it's a very useful test because, as we all know, that is a very common conundrum in the field. What's wrong with this patient? Are they in failure or are they having a COPD exacerbation, right? So I guess I would have thought that by now most of you would be using iStats in the field or in the emergency room. tell me where are you all working? I mean, I see fire departments. So that's, I understand why you're not using ISTATs. Okay. So I think that's probably why. The QA requirements on these things is quite extensive. So, you know, if it's not properly QA'd, it won't work. If it's QA is foiled at some point in time and you're out on a run and you want to use it, it doesn't work. It takes a couple of minutes to re-QA it. So there are reasons why people don't use them in the field. I would say that many interfacility transport companies have started using them. And I just wanted you to see, not every test is available. We talked about a lot of tests. However, most of what we talked about here today are things that are possible to be checked portably with an ISTAT device in the back of an ambulance. Each of these tests is done with a little chip that has to be popped in. And some of the chips do 1 or 2 things. Some of the chips do 5 things. It's very expensive, costly. The QA, I can understand why a small community fire department is not going to have these expensive devices that require all that maintenance. But these have become very popular, certainly in the hospital, in critical care areas, where I don't want to wait for the lab to run the test. I need to know now. Also in the field, doing interfacility transport, because I can, on a 4-hour transport, if I lived in North Dakota, where 4- and 6-hour transports are not uncommon, I may need to be checking somebody's potassium 1 or 2 times in that run. So that's what that device is. I was going to talk about it in a different way because I thought many of you would be carrying it, but since you're not, I'm not going to talk about it in that way because it's meaningless to you. Good.